I've always had a passion for improving clinical deterioration. Clinical deterioration in pediatrics is when a child who is hospitalized suffers a change in physiology that requires critical care services and transfer to the ICU. I'm always looking at how can we intervene earlier and limit harm to children and improve their outcomes. And to me, focusing on how we can best approach critical illness before it develops on the floor, before they really have more severe organ dysfunction, is the right place to start. I'm trying to understand how experts reason about clinical deterioration in children to help inform how we can improve rapid response systems for supporting the diagnosis of critical illness. And we capture this with something called the emergency transfer metric, which is really looking at children who come into our ICU from the floor and need life-saving therapies within 1 hour of transfer. It helps us to capture kids who have had some decline in organ functions that happened suddenly or was unanticipated on the floor. To improve our diagnostic excellence in clinical deterioration, we're taking a learning health system approach, really focusing on the data, the processes, and the ways to bring that learning back to the user. At a data level, we are leading a multi-center collaborative to learn about diagnostic failures in deterioration across various pediatric institutions in different care settings. We're also trying to build our data pipeline for understanding diagnostic reasoning in the inpatient setting by using user access logs. And the third part is really trying to understand how we can take that data and turn it into diagnostic reasoning interventions. And to do that, we're using electronic health record simulations and interviewing experts as they reason through children at risk for deterioration. These electronic health record simulations are essentially presenting a ICU doctor who would normally work as a critical care outreach team provider to review this child and their electronic health record data for risk of deterioration. And what we've learned is that the data that is salient to them seems to be very distinct from what we've identified as diagnostic failures in the past. They're often hypothesis generating up front and then really seeking unique data for those diagnoses. They also often can forecast where they think diagnostic failure might occur. A lot of our approach really focuses on finding common high-risk scenarios that we know have happened and bring safety learnings from those back to providers so they can be better in the next scenario. We're also doing systematic analysis of our rapid response system in general to understand where are we failing and what are the specific patient populations where we underperform relative to our average. My next steps for this project are twofold. One, we're continuing to validate some of the user access log data that we've used to learn how providers reason in the EHR. Second, we are currently reviewing our expert interviews to really pull out the diagnostic processes that they are doing and the diagnostic processes that they are forecasting so that we can bundle those into diagnostic roadmaps for deterioration. I keep seeing opportunities where if I could have the smartest minds who are thinking about this supporting that next resident physician or the next clinician who's taking care of the next patient, I think we could improve care for kids. And in 5 or 10 years, my hope is that we have artificial intelligence-based systems that can digest some of this expert learnings from system failures, pull that context from our healthcare system, and provide that meaningful data back to the user who is actually taking care of the next patient.